Dr. Iqbal, what made you go from clinical medicine to having that dual role of being a clinical leader as well?
I think I've always been a reluctant administrative leader. In my residency, my third year, we had a chief resident. We only had one, and he left after 2 months to just go pursue a career, and so we were left without a chief. And so the colleagues voted me to be chief, a third year chief. We didn't really weren't common to have third year chiefs back in the day, but so my colleagues selected me, and the reason they said that they selected me was the chief does the schedule, and they said that I would be fair. I would be the most fair person to do the schedule. So that was easy being the chief resident, and then I was junior faculty at my residency for a couple years, and then I actually worked at a county clinic for several years before I joined Kaiser Permanente. And then when I came to Kaiser Permanente, um, the my chief had I was here about 3 years, and my chief asked me to be FUM or module or pod lead. We have about 15 physicians in each pod, and I told him I couldn't do it because I was most junior, and there was no way I could lead people that were so senior to me. But he was one of those old-fashioned chiefs, and he kept asking me, and I kept saying no. And then one day he just sent the email out that I was the new pod lead, and so I was stuck in that position. So it's kind of just been like that. But I think, like Dr. Pacheco said, that if you're responsible and you're honest and you're fair and you answer emails and you want to do what's right, you want to do what's right for your group, for your colleagues, and especially for your patients, I think it just kind of comes your way. And so, my experience, it just kind of came my way in all different aspects. I love to teach, and that's one of the reasons I came to Kaiser Permanente. And we've been in and out with residents and students over the years. But when they pegged me for administrative duties, I said, no, I don't want to be the boss of other doctors. And they were like, no, it's not the boss. But, you know, if you have a knack for it, if you're just fair and honest, I think they'll peg you for it.
I agree with you 100%. And Dr. Runis, you've scaled up into a leadership role fairly quickly in your career. Can you speak to what drove you to want to become a clinical leader?
Sure. I guess I would say that it's a personality trait that's probably uh, similar to everybody who's on the panel, in terms of you don't you don't necessarily have to be asked to be a leader, because just by virtue of being competent and being like being willing to accept more responsibilities and looking for new challenges, then leadership eventually just finds you. You're like, oh, okay, that's somebody that we need to cultivate. And then so just again, I kept my head down. I just wanted to be the best family medicine physician I could be. And then, as that turns out, that was the kind of material that leadership that the C-suite wanted to see. So I got tabbed, and then I looked at it as an opportunity to not only advocate for my patients, but also advocate for my fellow providers in my clinic, so that I can then be a voice for them. Because then, instead of just to as a way of amplifying my voice, instead of just being a staff physician, by being a director, then now I can really try to help affect change. And I think that little bit of having a little bit more responsibility is might be a little bit can be a little addictive, because now I'm looking for more responsibilities and more ways that I can try to change things and make things better. So again, I would say that, again, most of the people who are watching this forum right now, you got to med school not because you were a slacker, right? You got to med school because you were driven. You wanted to pursue this career of being able this very honorable career of trying to help people. So I would say, just really tap into that. And then to me, actually, I feel like it's going to help with my career preservation, because they keep talking about nowadays, physician wellness is a very important thing nowadays, and physician burnout, and being able to take a little bit back from the everyday seeing patients, having a little bit more administrative time, is actually kind of healthy for me to be able to say, like, this will allow me to serve for a longer period of time, and also hopefully make it better for my colleagues who are working in that front line day to day. So again, that opportunity to be able to affect again, both my patient, more so my patients, and then also my colleagues in a greater manner versus just being just a staff position. I think that was an opportunity I couldn't sit down.
Thank you again to you, Dr. Runas, Dr. Pacheco, and Dr. Iqbal for your time today, and well-accomplished backgrounds as clinicians and as leaders within primary care. Thank you all. I'm going to hand it over to Leah Grant now to give us some questions from the crowd that is viewing us.
Yes, and that was amazing. Thank you so much for taking the time to speak and review those answers and just give real life experiences. I would say that's probably the best of this all, the real lifeness of everything. We do have one question that came, and I would say this will be great for all of our panelists to answer. What might be some day-to-day differences between hospital-connected clinics and family or multi-specialty health centers, i.e. patient panel differences, post-discharge follow-up numbers, specialist referrals? So considering that you all have worked in different settings, what would you say is the key difference between working for a hospital-connected clinic or an FQHC or a multi-specialty group? And Dr. Iqbal, we'll start with you.
Well, I can say that when I worked for the county, I just felt like it was all me, 100%. I didn't feel a personal connection with the specialists. I did have specialists I could refer to, but I didn't know when they were going to see the patient, that type of thing. And sometimes I had difficulty getting records from the hospitals, but mind you, I'm a little bit older and we didn't have EMR, electronic medical record at the time. So, but working at Kaiser Permanente, a multi-specialty center, is it's just amazing as far as getting your patients follow-up. So we can get patients in with specialists right away. I don't see people falling through the cracks, so to speak. I feel very comfortable with my colleagues and my specialists, and I'll be really honest. There were days I lost sleep when I worked at the county, worrying about patients because they couldn't get in to see a specialist for 6 weeks. What was going to happen if they crashed in between? It was just going to be me. I just felt very isolated. But here, I don't lose a night's sleep. I know that I have specialists I can call. And if the patient's not going to be seen within 2 weeks, I can still call them for some advice. And so we're huge, but we're very integrated. And most of us, almost all of us, know each other, and we're on first name basis. So that's the biggest change for me in the 3 areas that I've worked. I think I just feel the support in a bigger facility.
Thank you so much for that feedback. Dr. Runas, I'll pass it to you next.
Sure. Again, I would say that I would echo Dr. Iqbal's point. Working at FQHC is kind of like working at county. In terms of the patient population, it's not as integrated. I can't just say like I have a specialist under my roof who I refer to. We have people in the community who are contracted with. So then, again, it's the game of making sure that there's good follow-up, that they actually send the facts over or the reports, medical records that they're supposed to. Thankfully, that is improving slightly. For instance, like 2 years ago, we instituted Epic as our EMR, so thankfully we can see all of KP's notes now. And then UCLA and some Cedars, all the different hospitals that use Epic in the area. So in that regard, sometimes at least I can be able to have that in-house, because that's one thing I missed from county, was that from residency, was that once they were admitted to the hospital, once I saw them in clinic, I had all their records already. But patient discharge from a hospital that I'm not affiliated with, and it's like, okay, well, we're gonna have to start from scratch here, and that's frustrating. I know that's not a problem that Dr. Iqbal has with Kaiser. So from that regard, yeah, there is a little bit more probably some extra steps that have to be taken to make sure that there's quality, to make sure that there's good follow-up. And then unfortunately, some things that are systemic that may not be under your control. In terms of, like, again, if somebody who doesn't have insurance, doesn't have citizenship status, then there's kind of limited in terms of the access that's available. So you just kind of do the best you can. But again, working where I work, I know that our organization has tried to make that better in terms of we have a hospitalist team now, so that when there are discharges, the post-discharge notes, the hospitalist notes, are actually incorporated in the EMR right away. So at least those discharges, I know that I can I can follow up on right away. But again, if somebody goes to another hospital somewhere else, then it's just kind of, it's a grab bag of what can happen. Yeah.
Awesome. Thank you for that, Dr. Runas. And Dr. Pacheco, we will finish up with you.
So I have a little of both, because I'm not a closed system like Kaiser Permanente, and then we don't have a hospital everywhere where we have primary care offices. So when it's seamless, it's a patient admitted to one of our campuses, and then I too have Epic, so we can see everything. And so the transition of care is there, the follow-up, specialty, everything that we need is done, and that's from an admission perspective. But the other constraint that we have at Geisinger is that we have a large geographic footprint. And so there may be specialists outside our system that are closer for the patient to travel to versus getting into one of our hubs, which would be much further for them to go to. The good thing is that with some of that those exchange key high networks where we can get information across our electronic medical record, when we can, we do. But I deal with it in both ways. I deal with it out of system, specialty hospitalization follow-up, and in system. And by far, I think the key here is communication. How well is that done? And it's easier when it's done, on one of our campuses. When it's not done, it's a little bit more challenging. Getting old records faxed over, an ER report or a discharge summary or something like that. But I think, what has changed for us in primary care across the board and for us here in this country is that we are really moving towards a value-based system. And so everybody has their eyes on the prize about this, and it is important. And so regardless of where they go, for the most part, we're kind of working together for the good of the patient, and so they're not getting readmitted or having some untoward consequence of a comorbid or not. So it's a little of both.
Thank you so much for that feedback. And Dr. Runas, Dr. Iqbal, Dr. Pacheco, I want to personally thank you for taking the time to speak to our participants, speak to our residents today. It's been an amazing panel discussion, and I know the panelists are very appreciative of you taking the time out to share your personal experiences as well as expertise with them.